Good morning, everybody. I really actually welcome the opportunity to talk to someone about something other than COVID-19, which I, in a lot of ways, feel like is all I've been talking about for the last year and a half. Anyway, so what I want to talk to you about today is quality improvement, outcome research, and sort of that sort of blended continuum between the two, and maybe even help us begin to think a little bit about how to sort of tease those apart, and if find somewhere to sort of draw that line of where you're moving from quality improvement into outcomes research, and how you can begin to use both of those to sort of how they can sort of interact and interchange together. I also want to thank Dr. Karen Effinger. She's given this talk in the past and was kind enough to allow me to use some of her slides as a little bit of the seed for this talk. So I wanted to give her recognition for that. So the outline today is start by talking a little bit about what is quality improvement. And then we'll move into sort of talking about what is outcomes research. Then we'll talk some about how to distinguish between quality improvement versus outcomes research, especially as it relates to IRB approval. And then finally, we'll finish up at talking about how you can begin to take some of the quality improvement efforts that you may be involved in and move them into more of a realm where they might be have some outcomes research component to it. So let's just start and talk about quality improvement. And I think the best way is to start kind of back towards the beginning of everything, when the Institute of Medicine published its sort of landmark report back in 1999, titled "To Err is Human." And this was really kind of the first time in a systematic way that a lot of the errors and safety issues and quality issues that were present within healthcare really, somebody really shined a light on them and showed that it really was a big problem. You can see from the number of injuries, deaths, and costs just estimated from this report, it highlighted the problem. And this really was kind of the catalyst that really began to have healthcare begin to look at itself and begin to think about how we could be better. This was followed a couple years later with this follow-up report, Crossing the Quality Chasm. If sort of To Err is Human is sort of the throwing the gauntlet down, showing about all of the problems that we had, Crossing the Quality Chasm was sort of all right, what are we going to do about it? And it recognized that there were some serious quality issues in healthcare. But these were really very much a product of sort of poorly designed processes that had been put in place over decades, and not really bad people. And that things could be improved, but it was going to take a lot of work to redesign those processes. Now, a little bit more recently, but gosh, almost 10 years ago now, there was an additional report from the Institute of Medicine called Best Care at Lower Cost. And this began to highlight a lot of the waste and inefficiency that we see in healthcare. And you can see that from this report, they estimated about 30% of all healthcare costs in some way is waste, estimated around $750 billion of wasted resources, care, and whatnot. And all of these inefficiencies result in suffering. The report also estimated or highlighted some of the inequities in care that span across the United States, where estimated based on 2005 data, if all states were sort of performing at the quality level of the best performing states for different metrics, it would estimate it would have prevented about 75,000 deaths. So again, big issues in quality and safety. And from this, the Institute of Medicine sort of highlighted or put together these 6 domains for quality care. The first is safe care. And this is pretty obvious. People should be able to receive care without actually being harmed by the care that they're trying to receive. The next is care should be effective. It should be care that is delivered, treatments that are given should be based on the most up-to-date science and evidence-based medicine. Care should be efficient. Just like I highlighted in the previous slide, we should avoid unnecessary care and avoid waste. And similar to that, care should be timely. Patients shouldn't have to wait around. There shouldn't be delays in care, delays in reports, delays in receiving care. And care should be patient-centered. Patients and their families should be incorporated into the decision-making process, and things that are important to them should be included in the decision-making process. And then finally, care should be equitable. Care should be the same regardless of gender, race, sexual orientation, whatever. So quality improvement, I think, is well defined by the Agency for Healthcare Research and Quality, or AHRQ. In healthcare, quality improvement is the framework we use to systematically improve the way care is delivered to patients. Processes have characteristics that can be measured, analyzed, improved, and controlled. And I think this encapsulates what we're talking about when we talk about quality improvement. So what is quality improvement? So the ultimate goal when we think about quality improvement is to improve the care that is being delivered to patients. So it's really focused on the processes of care. And it's also focused at an institutional level. And that can be a single unit, a clinic, an emergency department, an entire hospital, or even a healthcare system, but it is very much focused on that particular institution. So it's local improvement. It is also very much focused on the how. How are the interventions being put in place? How are things done? How are the processes being performed? And it's an iterative process, as we'll see in talking about some of the methodology that we use for quality improvement. And there are multiple frameworks that are out there. Many of you have heard of Lean, Six Sigma, Model for Improvement. For the sake of this talk, I'm going to focus really on the Model for Improvement, which is an improvement framework that has been very much adopted within healthcare and is used in multiple different institutions, and is also the primary framework sort of supported and used by the Institute for Healthcare Improvement, or IHI. So when we think about an improvement project, there's 4 kind of phases of an improvement project that I think are important for us to think about as we get started. At first, there's the innovation phase, and this is really sort of the discovery phase, trying to understand what is your problem, what are the gaps, and what are some opportunities that are out there that might result in improvement. And then you move on into the second phase, which is actually testing that in both small scales, but then expanding that up and increasing your learning over time in sort of this iterative process, finally leading to a point where once you feel like you've really gotten all the bugs worked out, now you move into an implementation phase where you're actually embedding this new way of doing things into the way that care is being delivered, so it happens in a consistent way. And then finally, spreading that improvement to other areas. Two of the biggest challenges in quality improvement, I think, are one, our ability to implement something, sort of embed it in the way things are done, so we don't lose our gains aren't eroded over time, but then also spreading that to other areas. We see this a lot in healthcare, these pockets of excellence. This unit's doing something very well, but they never really figured out how to spread that to other areas of the hospital. So now I'm going to talk about the model for improvement. So this is, again, a really good framework to think about when you're thinking about improvement. And I think it's really easy for us as healthcare workers to sort of grasp this model. It's very simple, and it, in a lot of ways, employs the scientific method. So it's easy for us to sort of wrap our brains around. It starts with 3 questions. The first question is, what are we trying to accomplish? The answer to this question is your goal statement for your project. We often use sort of a SMART aim as a way to really sort of make this very granular and exactly what we're trying to accomplish. But in order to answer this question, you have to begin to understand your process and what's going on, where the sort of problems are, what your baseline data is to sort of inform the answer to that question. The next question is, how will we know that a change is an improvement? All improvement requires change, but not all change is improvement. Not all change is an improvement, and in order to make that distinction, you have to collect data and measure it. And we look at this from a number of different lenses in quality improvement. You have your outcome measures, and these directly relate to the goal that you're trying to improve. So for example, surgical site infections, my outcome measure would be the surgical site infection rate. But then we also look at process measures because, again, if you think about quality improvement, what we're actually doing is redesigning processes. So you have to measure those processes to understand how they're functioning in relationship to the various changes that you're putting in place. And then finally, we look at balancing measures. And these are measures that look at sort of downstream consequences that may result in our improvement. We may do some things to improve antibiotic timeliness administration in the operative setting, but that could result in delays in care. And being able to track that and recognize that helps you to make sure that the changes that you're making don't leave lasting negative impacts. And then there's this framework for testing a change and learning from it, these plan, do, study, act cycles, or PDSA cycles. I want to take a moment and just talk about some of the differences between collecting data for research versus quality improvement, because there are some similarities, but there's some important differences. I think first and foremost is when we think about data for quality improvement, it still needs to be valid and reliable, just like when you're collecting data from a research standpoint. Messy, inaccurate data is still not useful for quality improvement, just like it doesn't lead to valid results from a research standpoint. But to think about the differences, I like to use these two different images of an image of a lake and an image of a stream to sort of highlight some of the differences. When we think about measuring something for research, think of it, it's a very confined, controlled process. We're trying to control for every sort of all the variables that we can, except for the one that's under study. Kind of like the water in a lake, it's a very controlled setting. On the other hand, when we think about quality improvement, you're trying to measure what's going on in a dynamic, real-world, ever-changing process, kind of like measuring a stream. While valid data is very important, you have to make some concessions sometimes in order to collect. You don't have the luxury of collecting quite as much data or quite the same way that you do for research. And the goal is to collect just enough data to inform the improvement process that you're trying to make at any given time. So for example, some work that we've done in the past to improve hand hygiene compliance. We've had to spend a lot of time training our observers to make sure that their hand hygiene observations were as valid as possible. So we had accurate data, but we couldn't necessarily measure every single hand hygiene opportunity that occurs in the hospital. We had to collect a sample, and we knew that if we got at least 40 observations for each unit at a given period of time, let's say a month, we knew that would sort of remove some of the sort of variation in sort of percent hand hygiene compliance that might come with a very small sample size. So it gives you a sense, just enough data to help inform our improvement process. But then maybe we're focusing on, we see from our data that there's some poor compliance in physicians. We can then adjust our measurement to focus on some additional observations of physicians to guide our improvement work and interventions that are directly focused towards improving physician hand hygiene compliance. So you see, it's a little bit more adaptive process when we're measuring for quality, but you still need valid data. There's also this plan, do, study, act cycle for our way to test things. So it's very much like a mini science experiment. You're planning your experiment, you're making an assessment or a hypothesis about what you think is going to happen. How much improvement do you think is going to happen with this change that you're going to test? Well, what are you going to measure to know whether the change that you're making is resulting in an improvement? And then you actually do the test. You run the test, and it should be over a finite period of time. It is a test. The test has an end. And then you need to stop and study and learn what actually happened, what went well, what didn't go well, and make some assessments on that, and then act on it, which can very often results in some refinements of that test and some retesting, either in the same setting or expanding into a broader environment. And that's the other part of this sort of iterative adaptive process with quality improvement is you often have multiple linked test of change, starting very small in a very simple, controlled environment, maybe one patient, one day, one unit, 1 week, and then looking at it in different settings. Maybe you started during day shift, but you really need to understand how things happen on night shift to really know whether the change that you're making is going to work in all settings. And you continue to test, learn, refine, and expand until you get to a point where you really feel like you have a well-designed test that functions well in a real-world setting, and then you move on to implementation and then hopefully spread. And we also, when we look at quality improvement, we're also focused on data over time. This is an example of a control chart. This looks at CLABSI rates in the Scottish Rite PICU over time. It's by month. It's a rate of CLABSIs per 1,000 line days. The dotted line represents the control limits, and these are set at typically set at 3 standard deviations above and below the mean. So if something lands outside those dotted lines, it's statistically very unlikely to have occurred by chance in what we call a special cause variation, and something that's worth exploring because it's a sort of a non-random event. Maybe it happened because of the intervention you put in place, or maybe it happened because of something that acted on your system, but it's worth learning. There's also some rules that, the blue line represents the center line or the mean for that data. And there's some, if data is occurring randomly, it should be bouncing above and below the mean at a fairly consistent cadence. But if all of a sudden your data begins to fall all on one side or other of that mean, again, that's another situation where your data is behaving non-randomly, and hopefully, as in the case here, is the result of an intervention that was put in place. And you can see, and this is what's nice about control charts and showing data over time, is you can share the story of what you've done and show how the interventions you put in place may or may not have impacted improvement, and demonstrate this in a very compelling way. Now, there's a number of examples of quality improvement out there, and these are just some of them. Everything from improving safety, improving care delivery, such as flu vaccine or asthma care, reducing wait times, preventing readmissions, to improving equity amongst patients, making sure that people get insulin pumps regardless of their insurance status or race or whatever. So can we publish quality improvement work? And the answer is absolutely yes. It's very important for us, if you have a successful improvement project, to get that information out there, because it's very useful to other people in helping them understand what's worked and what hasn't worked. But there are some framework. There's a well-described framework for how to sort of take that quality improvement project and convert it into a well-written manuscript for submission. And those are the SQUIRE guidelines, the Standards for Quality Improvement Reporting Excellence. Currently it's SQUIRE 2.0, but this is kind of the framework for reporting quality improvement projects. And I pulled this directly from the Journal Pediatrics website for author instructions for submitting manuscripts. And they have a section in pediatrics called Quality Reports. It's focused just on quality improvement, reports of quality improvement projects. And you see here, quality reports are intended to add to our understanding of how to design and implement highly reliable systems of care that optimize the quality, safety, and value of healthcare delivered to children. But they also put the caveat in there, as you see farther down, reports of clinical trials to assess interventions, whether interventions are effective or not, are better suited for regular articles. And we'll get into a little bit more of these differences as we move forward. And that leads to sort of the very murky question of, do you need IRB approval? More to come. So let's talk about outcomes research. So Don Abedian is thought to be sort of the father of outcomes research, and he defined outcomes as outcomes, by and large, remain the ultimate validators of effectiveness, of quality of medical care. This here is the definition for from the CDC Dictionary of Terms for what is defined as research. I won't read the entire thing. Basically, it is a systematic study to create new and generalizable knowledge for a lot of different aspects. Let's talk about outcomes research specifically, and this is a definition from AHRQ. Outcomes research seeks to understand the end results of a particular healthcare practice or intervention. End results include effects that people experience and care about, and that's one of the key focuses of outcomes research are the effects that are important to the end user, the patient, such as changes in their ability to function, not just morbidity and mortality. In particular, for individuals with chronic conditions where cure is not always possible, it's quality of life. And by linking care that people get and to the outcomes they experience, outcomes research has become the key to developing better ways to monitor and improve quality of care. When we think about outcomes research, the scope is very broad. It covers a number of different research topics, such as quality of life measures, effectiveness, cost, quality of care, patient-centeredness, appropriateness of treatment, access to care, and health status, and dives into a number of different healthcare arenas, such as disease prevention, screening, drug treatment, medical procedures, medical practices, diagnostic tests, guidelines, and health policy. So very, very broad. And outcomes research can focus on a couple of different levels. It can focus down at the patient level, almost at the individual level, looking at clinical outcomes, financial impact, health perceptions of the patient, and patient preference. So things that are much more geared towards the patient, outcomes that patients care about. But it also can be much more broad and focus on sort of health, all the way out to healthcare delivery, looking at cost effectiveness, health status, disease burden, decision analysis, and healthcare disparities, which can help inform healthcare decision making at a much larger, broader scale. In the same way, the possible benefits of outcome research are similarly broad. They can be all the way down at the consumer level, or at the patient level, looking at increased participation in the decision-making process, increased choice for what hospital practitioner or treatment options are available, assurance that treatments that they're receiving truly are effective, and assessment and development of interventions to improve the well-being, not just survival, of patients. But moving to healthcare providers, this can also be beneficial, and it gives greater certainty regarding the benefit of an intervention, helping inform us what treatments are better. This information can then go on to help create standards of care and guidelines to guide clinical practice on a much broader scale, as well as help us in sort of this shared decision-making responsibility. Moving on to healthcare organization management, again, sort of greater use of effective interventions and removal of ineffective or wasteful care or practices, creating an increased culture of emphasizing quality, and then cost savings. And then at a government standpoint, really just taking those things at the healthcare organization level and moving them even broader to a much more national or global scale with cost savings, informing healthcare plans, and targeting future research. I wanted to highlight this sort of figure that I think does a nice job of showing the relationship between clinical trials and outcomes research. You see here on the left, clinical trials like phase 1, 2, 3 trials, looking at specific treatments under study and really focusing on efficacy. Whereas outcomes research on the right is focusing on quality of care, access, decision-making, treatment objects, looking like prediction rules, and really looking at the effectiveness of care. But both of them ultimately are informing or providing information on outcomes. And these can go on to lead to secondary analyses, such as meta-analyses or decision analyses, but they both also help inform our decision-making process based on clinical decisions, such as creating clinical guidelines, or even policy decisions, such as informing resource allocation or coverage decisions. And there's number of methodologies that we use related to outcomes research. First is when we think about well-being and satisfaction. So we spend a lot of time talking about quality of life. There's health perception, and there's a number of validated symptom instruments that can be used to help inform sort of the health perception of patients based on various conditions. Functional measures, such as based on physical, mental, or social function. Preference-based measures, how well they prefer this intervention versus this intervention. And then patient satisfaction, which we often receive information on from hospital on how well we're providing good care to the patients that we see. Moving on, there's economic analysis. At the most simple level is cost outcome. And this is very simple. This is just what is the cost related to, say, a surgical site infection, or the cost of care related to an asthma admission or something like that. But then there's the cost that you move on to cost effectiveness, where you're comparing the incremental cost of treatment with the incremental benefit from a single outcome. So again, a little bit broader, but still very focused on the cost and effectiveness of a single intervention. And then cost utility, and this typically uses quality adjusted life years, or QALYs, as sort of the metrics sort of for understanding, sort of putting all of this together, sort of patient perception, what's important to them, their quality of life, which may be can be very important to patients beyond just morbidity or effectiveness of a treatment. And then decision analysis. And these are modeling studies which take into account sort of the evidence and data that's out there of the effectiveness of different treatments, cost, risk factors, prevalence of disease, various outcomes, as well as patient-associated outcomes such as quality of life. And they put these together in these sort of decision models that are based on published evidence and data that's out there to help inform decision-making processes. And then within that, you can do sensitivity analysis, or you can sort of adjust the effectiveness of maybe if you're looking at sort of the effectiveness of a certain antibiotic treatment, some studies may say that it's 80% effective, some may say it's 90% effective, or even broader. And you can factor that variation into the model to create a much more robust model that can help lead to decision-making process. And these can be very helpful in situations where you don't necessarily have the patient numbers within an institution to sort of understand what is the best way to deliver care. And there's a number of different places where we can pull data to inform outcomes research. You can go to administrative databases, the electronic medical record, clinical databases, clinical trial databases, disease registries, and even census data, which can be very useful when you're trying to understand overall denominators for various things that you're trying to study. So I also want to take a moment and sort of highlight PCORI, which is the Patient-Centered Outcomes Research Institute. This, I think, is a really great place if you're interested in outcomes research. One, it's a great funding apparatus. So if you're looking for funding, they do a lot of funding for outcomes research. But they also on their website have like loads and loads of examples of outcomes research projects that may be very helpful as you're trying to think through how I might design an outcomes research project, or what are some examples, what it might look like. This is a great place to go and look both for funding and examples. And I wanted to highlight just a couple that I thought might be relevant. The first is a project or study that was comparing two ways to manage asthma in African American children, the ASSIST study. And this was a randomized controlled trial, including a little over 200 African American children with mild asthma. And it looked at two different interventions, symptom-based management and provider-based management for their mild persistent asthma. And to sort of explain the difference in intervention, if the symptom-based management was if you were a child with mild persistent asthma, you just used your controller medicine, your inhaled steroid, when you were symptomatic, and also using your albuterol rescue medication, whereas the provider-based was given by, the provider says you take your Flonase or whatever, or Flovent, once or twice a day, every day. So those sort of differences, and they looked at symptoms. They evaluated lung function at the beginning and at the end of a year. And then they also did some assessments of both older patients and younger on their symptoms and their quality of life. And what they found is after 1 year, there was really no significant difference in asthma control, asthma exacerbations, lung function, or quality of life. Both groups actually got better. They did both receive asthma education at the beginning of the intervention. So they both got some intervention, but the big difference that they found was there was really no benefit for this daily provider prescribed inhaled steroid. And obviously the symptom-based approach used less steroids, and for a patient might be a little bit easier to manage, less medicines to refill, less doctor's visits to adjust medications and things like that. The next study was comparing antibiotics to surgery to treat appendicitis in children. And this compared the non-operative management with antibiotics, so 7 versus laparoscopic appendectomy. So those children that, and this was a non-randomized trial, obviously, because pretty obvious. So both groups got perioperative antibiotics, or got initial IV antibiotics, and then the antibiotic group received 7 days of oral antibiotics. And then they compared the effectiveness of that intervention of antibiotics alone, what percentage ended up having to have ultimately having a recurrence and needing an appendectomy. But then they also looked at health-related quality of life. How many days until they were back to sort of being able to function in normal activities, school, sports, things like that, as well as sort of longer-standing health-related quality of life and disability. And what they found was there's a 67% effectiveness to antibiotic treatment alone. And then the mean disability days for antibiotics alone was almost half, about 6.5 days versus 11 days for appendectomy. So the health care related quality of life was better at 1 month for the antibiotic group, but at 1 year, they were similar between groups. And I think that, if you're a patient trying to weigh different treatment options, this is very helpful in trying to sort of wade through, should we go to surgery? Should we just try antibiotics? And that's sort of where outcomes research can be very helpful in helping inform patients of the effectiveness of various decisions, the impact on their quality of life, so they can sort of better make some informed decisions. And we as healthcare providers can also better inform our patients of the options out there and sort of make these treatment decisions together. So now let's move on to quality improvement versus research and get into sort of that age-old question of, is it quality or is it research? So to start with this, I'm going to start with a story. And this was it's a very well-known quality improvement project to prevent CLABSIs. It was a collaborative project between Johns Hopkins QI and then the Michigan's Health and Hospitals Association Keystone Center for Patient Safety and Quality. This was funded by the AHRQ. It basically focused on this early ICU checklist to prevent CLABSIs. As you can see, the different components of this checklist here, which is still used today. Local ICU physicians and nurse teams were given the evidence behind this intervention, as well as some tools for teamwork and improvement. And then the local institutions collected data related to infections, catheter days, and then sent this de-identified data to Johns Hopkins for analysis. It's published in the New England Journal of Medicine. And part of this is because they saw some very dramatic improvements. Their CLABSI rate went from a baseline of 7.7 per 1,000 catheter days down to 1.4 at the 16 to 18 month follow-up period. Is this quality? Is this QI, or is this outcomes research? Well, actually, this wasn't as clear-cut as one might think. The Johns Hopkins IRB actually categorized this as exempt because the data were de-identified and the research presented minimal risk. But after publication, there was an anonymous complaint filed to the OHRP questioning whether this was in fact exempt research. And this led in, I remember when this actually happened, and it really turned into a giant stink. But the OHRP's response was this was non-exempt human subject research conducted without appropriate IRB review or approval. Although the data was de-identified and collected prospectively, it was done for research, not just QI. This multi-center work was trying to, on a much more generalizable scale, understand the impact of this checklist. So while on the individual level, at each PICU, at each of these different sites, the actual implementation was quality improvement, the systematic investigation and collection and analysis of the data was in fact research. And it could have been considered expedited, minimal risk with waiver of informed consent. So I think this was one of the early really powerful quality improvement studies that came out, but it also highlighted some of the challenges and pitfalls and the murkiness between quality improvement and research. So there are a number of similarities when we think about quality improvement and outcomes research. They both are focused on improving patient outcomes. They both are addressing a specific problem and have specific aims. They develop some sort of way to measure and analyze data and assess the impact of a various intervention, and then analyze the impact of that change, and it creates knowledge. But there are some important differences. Quality improvement is really designed to bring about and sustain local change. What you're doing in a quality improvement project, when I try to do work to reduce device-associated infections in one of the PICUs here, Children's Healthcare of Atlanta, I am trying to implement something to improve care here. But what actually works here may not necessarily be generalizable to some other PICU. Now, some other PICU might be very interested in what we've tried and what worked, but ultimately they're going to need to take that and they're going to need to apply it and test it in their own setting to determine whether it works or not. It's not generalizable. It is useful information and worth sharing, but it's not generalizable. Whereas outcomes research is really looking at the effectiveness of an intervention, but really with much more of a focus on creating generalizable knowledge. And I like this matrix as it is a nice way to sort of think about to look at some of the differences between quality improvement and research. You think about quality improvement, again, it's an iterative design, typically set in a local setting. That can be quite variable from, again, like a single clinic to an entire healthcare system, but it is still very locally focused. Whereas research has a more fixed hypothesis, a much more rigid protocol, and can be single center or multi-center. And the big key is the information that you're creating, although again, may be useful to others, it's not generalizable. Whereas research, you are trying to study something and create generalizable knowledge. I pulled this directly from the Emory IRB, which also goes on to sort of help provide some explanation between quality improvement and research. Again, focus for QI is local and specific to that institutional practice. It does not represent a broader population, and the conclusions are only intended to be directly applicable to that particular institution. There's no claim that those results apply outside the setting, and that's some of the big distinction. Now, it's always, and it's always a good practice if you have questions before you're starting a project, to reach out to the IRB. Certainly, it's always very useful if you have the intention to try to share your project either as a presentation or a poster in a national meeting or write it up as a publication. Most journals like to see that you have at least reached out to your IRB through a letter of determination for them to give the stamp and said, nope, this is quality, this isn't research, or yes, it is quality, but there's a research component to it. But most journals like to see that. And it's actually a very simple process. You can go into the IRB website. There's a link to sort of submitting a letter of determination. It's basically just a quick snapshot summary of your project, what you're doing, and then they quickly review it and should get back to you within a few days, letting you know whether they think that this is fully quality or there's a research component to it that requires some additional IRB evaluation. But that it is a short, quick step, but it is very helpful in sort of giving that sort of ticket that this truly has been reviewed and is quality, not research. I think there's also a great intersection between quality improvement and research. And I think this yin-yang symbol does a nice job of sort of showing that interaction. So you can have a research project that identifies a new intervention, shows the effectiveness of a new intervention, but we know that there's about a 17-year delay between research showing an effective intervention to where it becomes common practice. So that's where a research study showing the effectiveness of a new intervention, of a new test or a new practice, then can lead to quality improvement to help implement that in a much more rapid, much more sustained way. On the other hand, you can have quality improvement projects that through that work of quality improvement identify interventions that are probably worth some more in-depth study to determine whether they truly are effective. We often have these bundles of interventions that we sort of throw, kind of these sort of kitchen sink approach to improving various things like healthcare associated infections, but there probably is benefit to sort of testing those interventions on a much more systematic way to determine whether those interventions really do impact care. If you have a bundle of 5 interventions and now you're going through all this added effort of trying to implement each one of these bundles on interventions on a consistent way, but 2 of them really don't have very little drive on the outcome, well, that's wasted time and effort. And understanding that can be very useful. In the same way, you can also identify from quality improvement projects some gaps in care, disparities, potential bias in how we provide care that also may be worth exploring it more in depth with outcomes research. So finally, I want to finish up and talk about how to turn quality improvement into outcomes research. Again, I want to sort of remind us of the pillars of quality care: safety, effectiveness, efficiency, timeliness, patient-centered, and equity. These are important for quality, but also can be seeds for outcomes research. Looking at each of these just depends on sort of the lens and the focus that you're going after. There's a number of different questions that we answer or we want to answer related to quality improvement. What's the magnitude of the problem based on the available data? What tools are out there to measure and assess the impact, what's actually going on with the process? What measurement plans are out there? What types of changes could we test to try to improve this through PDSA cycles? What's out there? What have other people applied? What are some things that we've identified from our own data that might inform a change? As I said, kind of what's been reported in the literature? And will those results of the project directly improve patient care outcomes and processes? How much is the organization as a whole sort of invested in this? And then what's the sustainability plan? As I highlighted before, one of our biggest challenges is moving from local quality improvement to something that's sustained over time and spread. But then we also have some research questions. Do we have a clear question to be investigated? How do we hope to accomplish or answer this question? What's currently known about the topic? What are the risks and benefits to the patients that are being involved? What sort of study design are we going to use to measure and analyze the data? So some steps in turning your QI project into research is to identify those research opportunities. What are areas that have not been well tested? We have an intervention that we may or may not really know how effective it is. What's the assessment of the effectiveness? What sort of health disparities are out there? This is a huge area of focus, is looking into healthcare disparities. cost effectiveness of new methods, and how to disseminate this work. As you're thinking through this individually, it's important to research, sort of meet with your mentor or people that you're collaborating with, just like any research project, to set your hypothesis, your aim, create your study design, your data collection method, and your sample size calculations. Seek funding. Again, if you're looking at outcomes research, a good place to look is PCORI. There's a lot of great grants that are out there that are worth exploring. And then don't forget IRB approval. Again, whether this is quality improvement or research, it's always good to reach out to your IRB and just get their glance, sort of a expert set of eyes, just to make sure. We often have a tendency, it's quality improvement. And call things that are quality improvement sometimes that aren't. And again, it's always good to get a sort of outside set of eyes. So I want to finish up with just a couple examples. So this was a multi-institutional project to reduce CLABSIs in the PICU. This was involved 29 different PICUs, focused on the implementation of 2 different bundles, an insertion bundle and a maintenance bundle. Again, you can see all these different pieces of the bundle, and you can question how many of those are truly important to care. And this happened over a 3-year period, interrupted time series analysis. But within this was an 18-month non-randomized factorial design evaluation to look at the effectiveness of 2 specific interventions. So much more sort of systematic design. And what they did is they were focused on chlorhexidine scrubs, and then these chlorhexidine impregnated sponges, like BioPatch that a lot of us see on central lines, to look at sort of the effectiveness of these 2 specific interventions. And the way they designed it is each PICU was allowed to sort of choose how they wanted, they were doing all these bundles, but as it related to these 2 different interventions, they could choose what they wanted to do. They could either continue their current practice, whatever that was, or they could choose not to do either, or do one or the other, or both. And then through that, they were able to, with all of these PICUs, sort of combine together and assess whether these 2 interventions actually had any impact on CLABSIs. As you can see, this shows the CLABSI rate over time. This was pre-intervention baseline, sort of wash-in period, and then post-intervention. You can see CLABSIs decreased over time. You can see the compliance of bundles, the insertion bundle and the maintenance bundle here. But what was really interesting is through this design, this sort of factorial design, they were able to show that these 2 interventions really had no additional impact on reducing CLABSIs. And if you think about sort of healthcare cost, knowing that you don't necessarily have to sort of systematically implement all of this is a cost savings. So thinking about this from how did this sort of equate to sort of the research lens? And what each PICU did is they reached out to their local IRB to review this project. And the local IRB made its own determination of whether they thought this was straight up quality improvement or whether this was some form of research. And so each PICU, each center sort of IRB sort of made its own determination, and there was variation across all of these in decision. Again, depending on each local's IRB interpretation of what this was. Another example, this was actually a collaborative that that Children's was ultimately involved in, but this was an association with a clinical practice guideline for blood culture diagnostic stewardship in the ICU. So this was initially performed at Johns Hopkins, I believe. It was 24-bed PICU. It was a retrospective cohort to determine the effect of this quality improvement-based implementation of this clinical practice guideline. So they had 2 sort of main interventions, this fever symptom checklist and this blood culture decision algorithm. And this was implemented as quality improvement. So it was a quality improvement project to sort of test these interventions and implement these interventions. But they also were looking at sort of more systematic data of mortality, readmission, shock, antibiotic use, and things like that. And ultimately, you see the impact they had on total blood cultures and central line blood cultures over time. But it led to sort of this final conclusion: further studies are needed to define how differences in unit practices and culture could affect the effectiveness and implementation of these strategies. So again, sort of highlighting this is quality, although there was some research aspect to this, this was a quality improvement intervention, and highlighted that this project is really just, locally, the results of this really can only be sort of applied to the local setting. So this led to this multi-site collaborative. This was, I believe, funded by AHRQ, looking at multiple PICUs across the U.S. Again, like I said, Children's was part of that. In each site, again, we reached out to our IRB here to sort of look at this project, and there was sort of a quality improvement component where we were taking some of the interventions that had been used in the previous study and implemented those in our own way or added new interventions. So it was quality improvement, but we also were sharing de-identified data related to mortality, C. diff rates, CLABSI rates, and other things like that with Johns Hopkins, where they were doing sort of non-human subjects-based research. So there was two components to this. There was both some straight quality improvement and then some outcomes-related research. And finally, I just highlight this as an example of a situation where I think somewhat real world could inform and generate some outcomes research. So if you're working on a QI project to reduce hospitalizations in children with type 1 diabetes, when you look at your own internal data, you see that there's a significant difference in hospitalization rates for those that have private insurance and those that have Medicaid. And I think that for all of us, likely begins to generate some questions of why. Why is that? What are some of the differences between these two populations? Is it race? Is it socioeconomic status? Are there some biases in us as providers that are impacting sort of some decision makings that we make based on their race or socioeconomic or insurance status? So you can see that this quality improvement project could generate some outcomes research related questions. So in conclusion, QI and outcomes research both are valuable and for the patient experience and to improve patient care. Quality improvement projects are focused on local improvement, are really only generalizable to the local setting, whereas outcomes research projects really are focused on generating generalizable knowledge that can be used in a much broader scale. QI can lead to outcomes research projects, as I've highlighted. Don't forget the IRB. Again, often just a letter of determination can save you tremendous amount of woes down the road. And with that, I'll answer any questions. Thanks for your attention.